OPRE logo. Office of Planning, Research, and Evaluation. An Office of the Administration for Children and Families. Scott Cody and Mary Catherine Arbor sit at a table on stage in a hotel conference room. Attendees sit at round tables. A slide on the screen next to the stage reads, Rapid Learning, Methods for Testing and Evaluating Change in Social Programs. OPRE Methods Meeting, October 25, 2018.
Welcome. Thanks, everyone. Thanks, OPRE, for having us. Mary Catherine and I are going to try and do a sort of joint presentation here that hopefully will look like we've been rehearsing this together for several weeks. There's a chance it might look like we just met for the first time yesterday. One of those two things is actually true. Also, it might look like, we're both from Boston, so it might look like we were up late watching the Red Sox. I know that is true for at least one of us. I don't know if it's true for both of us.
Mary Catherine laughs.
So those of you who have heard me talk before know that, I feel like we are embarking on an era where we can use program data and rapid testing to help programs, target services, become more effective and improve rapidly. But the more I do this work, the more I see people looking for kind of the one-size-fits-all approach to program improvement. And there is no one-size-fits-all approach to program improvement, just like there's no sort of one recipe for making dinner.
Text, Scott Cody, Insight Policy Research.
What you make for dinner is going to depend on what you want to get out of it. Are you trying to cut carbs? Are you trying to eat more greens? Who else is eating? What do they want to get out of it? What do you have in the fridge? How much time do you have to make dinner? How comfortable are you doing something complicated? Those are the factors that are going to determine what you make for dinner. And similarly with program improvement methodologies, what you decide to do depends on contextual factors. I think that's one of the main things we want you to take away. Over the next 2 days, you're going to hear about a large number of different program improvement methodologies. They're all valuable. What we want to talk about is how do you figure out which approach to program improvement is right given a given set of contextual factors.
The slide reads Introductions and Overview, with photos of Scott Cody and Mary Catherine Arbor. Bullets read Why This Work Matters, Getting Started, Methods, Examples, and Final Takeaways. The next slide on the screen reads, Lesson Number 1, Move Past the Jargon. Below is what appears to be a crossword puzzle with red squares. The horizontal words read Rapid Cycle and Small Tests, while the vertical lines read the acronyms, PDSA, CQI, RCT, PDCA, and RCE.
So I'm going to start by addressing the jargon that was already referenced. There will be a lot of jargon over the next 2 days that you will hear. Those of you who may be relatively new to sort of the program improvement field, you might become overwhelmed or confused by the jargon. PDSA, rapid cycle evaluation, rapid cycle testing, small tests of change, PDCA, CQI. There's a lot of terms that will get thrown around, and they're confusing. In some cases, we have two terms or multiple terms that can mean the same thing. In other cases, we have a single term that's used in different contexts. I often talk about rapid cycle evaluation, and sometimes what I'm talking about is different than what other people mean when they're talking about rapid cycle evaluation. So what I'd ask, at least for the next hour, and hopefully maybe for the next 2 days, if you can kind of let go of maybe preconceived notions you have associated with some of these terms, some of the jargon, maybe any emotional attachment you have to some of the jargon, and just keep in mind that these different methods, they share a similar backbone, and they're all kind of headed in the same direction.
The next slide contains two graphics. On the left, a document with two loudspeakers pointing out. It is labeled, Data Reported Externally. The motivation is listed as transparency and accountability. A red arrow points to a graphic on the right labeled, Data Used Internally. It features a line graph, bar chart, spreadsheet, and pie chart in a circle with arrows pointing clockwise between each. The motivation is listed as practice change.
One way that I like to think about getting beyond the jargon is to recognize and think about these in the historical context. So rapid cycle evaluation arose and gained traction in the 1980s and 90s, initially using data to drive improvement largely through reporting data externally and focusing on accountability. And that occurred in multiple disciplines and was called different things at that time.
Text, Mary Catherine Arbor, Harvard University.
And in more recent years, we've moved towards use of data to inform improvements in practice that focuses on shorter time frames and engagement of frontline service providers in looking at and using that data to make decisions about practice. So I like to think about the spirit of these methods is to get beyond reporting data externally for accountability purposes towards using it to drive improvements in practice. And the different methods that you'll be hearing about over the next 2 days have varying, fall along varying degrees of rapidness and also use different amounts of engagement of frontline providers in looking at and using that data. But if we keep that spirit in mind and the history in mind, I think it helps us get beyond some of the jargon.
The next slide of Lesson 1 lists the following common traits. Start with program objectives. Identify a strategic change to test. Hypothesize potential improvements. Determine the appropriate measurement. Analyze the outcomes and make decisions.
So there are important differences among some of the program improvement methodologies that we'll be talking about. But in general, we think they share this sort of common set of principles, this common backbone. They all start with either implicitly or explicitly a set of objectives. What is it you're trying to achieve? What are you trying to change? They identify a strategic element, something to test to see if you can help achieve that objective. Importantly, they don't assume that that change is going to work. Sort of all of these methods go into it acknowledging that there's a chance that this, what we're testing actually might not work, and that's actually a pretty important component. They hypothesize, how this change might actually lead to the improvements that are targeted, possibly using a logic model. They determine the appropriate way to measure whether those improvements are happening, again, possibly along the way using that logic model. Then you run the test, you analyze the results, make a decision based on that, and then hopefully repeat on your path to improvement.
The next slide reads, Lesson number 2, start with the question. What are you trying to answer? To the right of a large, red X is the word method with an arrow pointing to the word question. To the right of a large, green check mark, the words are reversed, with an arrow pointing from question to method.
So I've already kind of said this, but I think it's important not to sort of blindly apply a program improvement, rapid learning method to every situation or any situation. You run the risk of either answering the wrong question or maybe answering the right question, but doing it suboptimally, inefficiently, or in a way that's just not useful. So we think that the best way to figure out the right method is to first really understand the context and the situation the problem that you're trying to resolve, and use that to determine which method to use.
The next slide of Lesson 2 reads, identify the question. 10 specific questions about relevant factors for choosing a method are listed.
So how do you do that? We've compiled this list of questions. It's probably not a comprehensive list, but we think these are some of the most important questions to answer in order to figure out what's the best method for rapid learning, for improvement. So let me walk through these. The first is, what am I trying to understand, right? This is pretty obvious, but it's obviously a really important question. And the more specific, the more explicit you can be in saying what it is you're trying to understand, that will not only help figure out what's the best approach, but that's going to help you communicate the approach to the folks who are on the ground actually incorporating this change into their day-to-day activities, the sort of frontline staff, as well as the people who are paying for your rapid testing. So being explicit about what it is and as clear as possible about what it is you're trying to understand is really the first most important thing to do. Similarly, what outcomes am I trying to change? Again, being as clear here as possible. Next, who's going to use the results and how are they going to use them? And I'll say, as someone who comes at this really from more of a traditional social policy research, randomized control trial background, I think we as researchers historically have dismissed this issue of, ultimately who's going to use the results and how are they going to use them. I think as a field, we're getting better at it. And I know that there are people here these next few days who are going to talk about work that they've done that really does incorporate, sort of the end user. But in general, I think we, as a field, have room for improvement here and really understanding the end user. We spend a lot of time focused on, minimizing bias and ensuring internal validity. And I think that those are important things to get right. But I will say that an unbiased, internally valid finding that is not useful is a useless finding. So we need to keep that in mind. What are the organization's priorities? Where does this fit in? Again, that can influence the nature of the design, how you go about the improvement effort. How confident do I need to be in the results? I like to think of this as what's the risk of being wrong? What's the consequence of a false positive, right? If I test a change and I see an improvement and I conclude that that change caused the improvement, what's the consequence if I'm wrong? In some cases, it might not really matter, right? I'm trying to improve program completion rates. I make a change, completion rates go up. Does it matter if that change caused the completion rate? Maybe not, right? In some cases, maybe not. In other cases, the change that I'm implementing, I'm testing it. If it works, I'm going to roll it out system-wide, and that could be expensive. And I want to be confident before I roll this expensive thing out system-wide that it's actually working. So in that case, the risk of a false positive is I'm going to spend money on something that's ineffective. Or what I'm testing will affect who gets what services, which beneficiaries get what services. And that's going to affect people's lives. And I want to make sure that I'm making a decision that doesn't lead people into ineffective services or down a path that's going to harm them. So what's the consequence of a false positive is how I think about that. How hard is it to implement the innovation? Again, that can definitely affect how you set up the design. How much will building and engagement of program delivery staff is needed? And again, this is something that I'll admit from the sort of research perspective, historically, maybe we have dismissed this too much. I think there are definitely folks who are getting much better at this. But if the inner thing that we're testing, if frontline staff who are actually incorporating it into their activities, if they need to tweak it in order to get it to work for them, or if they're going to reject it, if there's going to be some kind of like organ rejection of this change that you're implementing, you're not going to have a good test, right? Yeah, I'm pretty confident you're going to have an experiment that doesn't show that doesn't show an impact. So really assessing how much do we need to engage staff in kind of the implementation of what we're testing. What data are available? How soon do I need to know the results? What time is needed between when I make a change to be able to observe actually an impact on the outcomes that I'm interested in? And often those two things are in conflict. I sometimes usually need to know the results sooner before I can actually observe the impact. So in those cases, is there a near-term proxy that I can use as a measure of potential impact? So those are the questions we think, and we'll dig into these a little bit more, but that we think are important in order to begin to select your sort of program improvement approach.
The next slide reads, Lesson number 2.1, What am I trying to understand? A bulleted statement reads, How to apply established evidence, with a picture of hands washing with soap.
So I just want to illustrate one of these questions and how I tend to think through this. For the first one, the question about what am I trying to understand, there are situations where what I'm trying to understand is how to apply established evidence. So I don't need to prove that hand washing reduces infection. I don't need to prove that reading to children and providing ways to introduce new vocabulary that is not a part of their daily life helps develop language. I do need to prove or test how I get people in the front lines to apply that evidence across diversity and context.
Second bulleted statement reads, How to adapt established evidence to new context. Below are two pictures. One is a picture of a book cover that reads, G is for growing. The other is an illustration of a group of children with the logos for Sesame Street, International Rescue Committee and NYU Steinhardt.
Sometimes the question is how to adapt established evidence to a new context. So this is an example that's fascinating. It's from the MacArthur 100 Million and Change Initiative. And there's a team from the International Rescue Committee, Sesame Street, and NYU Steinhardt who are adapting Sesame Street interventions to Syrian refugee families across the Middle East. So there's 30 years of research that show that Sesame Street, the program, has influenced childhood outcomes for 3 to 5-year-old kids in the United States. We think the underlying theory should apply similarly to 3 to 5-year-old Syrian immigrants, but how to apply Sesame Street in those contexts is the question they're setting out to answer. And they're going to test and adapt a home and center-based approach for 1.5 million children and programming across the Middle East for 9 million families. Another interesting example that I and others in the room are involved with is the Home Visiting Applied Research Collaborative that's looking to see how do we adapt evidence-based home visiting model components, active ingredients, to better improve outcomes for all families. Right?
Bulleted statement reads, how to discover new evidence.
And then the last is how do I discover new evidence? If there's something we really don't know how to do, that should play into which designs we choose.
The next slide reads, Lesson number 2, Example, Highest Priority Considerations in 2006. The slide shows the same 10 questions introduced on a previous slide, with some marked as priority questions with answers. For example, what am I trying to understand? Is a priority question, with the answer being impact of professional development for preschool teachers. The other priority questions are what outcomes do I want to change? How will I use the results and who will use them? What are the organization's priorities, and where does this issue fit? And finally, how confident do I need to be in the results?
So here's an example. I've worked on a project in Chile. This was funded by a Chilean foundation, Fundación Oportunidad, and Harvard worked with the University Diego Portales to work on this project, Un Buen Comienzo. In 2006, this foundation set out to improve the opportunities available to low-income children. Chile is a stable and prosperous democracy, with some of the highest levels of inequity in the world. So the country as a whole has established early childhood education as a priority, and 4 and 5-year-olds have universal access to preschool in Chile. The quality of that is a concern to Chileans and others. So this foundation said, what we're trying to understand is the impact of a professional development intervention for preschool teachers. The outcomes are classroom quality and child-level language and literacy outcomes. They wanted the results to be used to influence policy and that policymakers would use these results. And the organization's priorities were really completely aligned with this intervention. They want to be a national leader improving the quality of public early education and children's opportunities. In 2006, they wanted to be completely confident in the results, so they put a premium on experimental design. At this time, the other questions really weren't priority questions for this foundation. How hard is it to implement the innovation and what data were available? They were willing to invest to overcome implementation barriers and to create data collection systems. How soon do I need to know the results? They were very patient. They understood that it was going to take probably 2 years for a change in professional development to affect children's language development. And there was no near-term proxy for that impact, and so they were willing to collect it over a duration of time. They also knew that the premium they placed on experimental design, which required cluster randomization, necessitated a series of cohorts. So these were 2-year cohorts that were enrolled sequentially. The results of this study were available in 2011, and we found that the intervention had a large positive impact on classroom quality and null impacts on average child-level outcomes. There was a positive impact on several language outcomes for a subset of children who attended the most. And that brings us to 2011. Many institutions would have walked away from this intervention at this time. There aren't a lot of funding mechanisms that are set up to say, we're going to invest for 5 years in an intervention, and then we expect to do more, right? But this foundation was faced with a decision. They could either start over with something new or they could continue with this. And what they decided was that the experience of the previous 6 years showed they had already adapted, we had already adapted the best existing evidence as best anyone could through a participatory design, and this intervention was implemented well. The mixed positive effects suggested that parts of this theory of change were solid, but that it needed to be improved. So in 2011, the priority questions were different. What we were trying to understand was how to change the intervention, the same intervention, to maintain or improve impact on quality and achieve impacts on child-level language outcomes. The outcomes were the same, classroom quality and children's language and literacy, and the use of the results was going to be slightly different to redesign this intervention, and it was going to be used by the implementation team, program recipients, and program leaders. The organization's priorities were still to be a national leader, but they felt they needed to develop a more effective intervention to take on that role. And they changed the time frame. They wanted to know these results in 1 to 2 years. They still didn't place priority on how hard it was to implement the intervention, and they reduced the priority placed on how confident we needed to be in these results. So the message of this is really to demonstrate that as we answer these questions, we can and should anticipate that the priorities may change for an intervention depending on the developmental stage of the intervention itself, the evolution of the evidence, and we'll talk a little more as we go on, the evolution in the workforce who's delivering the interventions.
When we first started talking about doing this presentation, the concept was I would do play-by-play and she would do color commentary. I think I just feel compelled to do that because I keep wanting to talk about the Red Sox. Sorry, I know, someone from Boston who keeps talking about their sports fans. We're endeared everywhere, I know.
The next slide reads, Selecting Comparisons. It contains several boxes surrounding one center box that reads, Identify Optimal Comparisons. The other boxes read, Historical Trends, Performance Targets, Individual Client History, National Benchmarks, Participants, Forecasting, Program Model, and Non-Participants. These boxes contain various graphics associated with their topics.
Okay, so the foundational questions are really important to help figure out what's the best approach in a given context. After you've answered those questions, one of the next things to consider is what comparison are you going to make? How are you going to measure whether there's a change in the outcome? And there are a number of options for making comparisons, and I think the important thing I want to emphasize here is that the different comparisons are really answering different questions. So you need to pick the comparison that's going to be most beneficial to your context. You can make a comparison to historical trends for your program. After we make this change, does the trend in whatever increase? You can compare relative to performance targets. Are we better able to achieve the performance targets that HHS has set for our program after we make this change? You can look at individual client histories. So for a given beneficiary, or for a set of beneficiaries, once we implement a change in their services, do they have a change in outcomes? You can look at national benchmarks. Are we more like our peers? Are we more like other states after we implement this change? You can look at other participants in the program. So do participants with the change have different outcomes than participants without the change? You can use forecasting. After we implement the change, do people do better than we would predict they would do? You can compare relative to the program model. After we make the change, are we better able to implement this with fidelity than before the change? And of course, you can look at non-participants. So are program participants with the change faring better than people not in the program at all? Each of these comparisons, like I said, is answering a different question.
The next slide reads, Selecting Your Method. It contains a table with a list of methods on the first column. The second and third columns are labeled Level of Confidence and Methodological Complexity. Each entry is highlighted in red, orange, yellow, or green, with red representing low, orange moderate, yellow, moderately high, and green high. The table identifies the level of confidence and methodological complexity for each method.
In addition to selecting the comparison, you also need to select sort of what's the methodology for making that comparison. It can range from really just a naive comparison to statistical control charts, propensity score matching, randomized control trial, a Bayesian adaptive randomized control trial, and that's a plug for last year's OPRE conference, which materials are online. And so there's a couple of points I want to make about this. I could spend a whole hour just talking about this slide, and I'm not. I'm going to spend maybe a minute. But there's a couple of points I want to make. One is that as you kind of go down this list, you have increasing levels of confidence that what you've tested, if you observe a difference in outcomes, a change in outcomes, that you have increasing confidence that what you're testing is causing that change in outcomes. So as you go down this list, that the level of confidence increases, but as does the methodological complexity. So the further you go down this list, the more complex the methods are, the more likely it is you're going to need to bring in someone to help do the analysis. And that's important to consider in this context because sometimes you actually want the program staff to be doing the comparisons. You want the frontline staff involved in doing the analysis. And the more complicated you make the analysis, the harder that's going to be. So that's another factor to consider. I think a lot of people would assume that I would have a third column here with time and that there'd be kind of a similar relationship that the further you go down this list, the longer it's going to take. That's not necessarily the case. And I'm saying not necessarily because I'm expecting to get questions on this, so I'm hedging. But I can do a randomized control trial in one day under the right circumstances, right? If I have, if I know what I'm testing can actually have an impact, I can observe that impact within a day. If I can get that data that I need to observe the impact within a day, and if I have a sufficient flow of people through what I'm testing in a day, I can do an RCT in a day. I think Google's doing that kind of thing all the time. So the factors that drive how long these different methods take to implement, they're not necessarily the method. They include, do I have access to the data? How long is it going to take me to observe the impact? And do I have sufficient sample to identify a meaningful impact?
The next slide reads, measuring improvement. Bullet points read what data are available and what time is needed to observe an impact. Is there a near-term proxy for the impact?
One of the factors that will influence where you make those choices is the data that are available and the time needed to observe the impact, whether or not there's a near-term proxy for it. So use of a rapid cycle evaluation approach will be informed by this. The example from the Chilean study of children's early language and learning skills, there was no near-term proxy, right? So that was a challenge. And the process measures were instructional time and instructional quality, which have a couple of different measures. And I want to illustrate that what the program wanted to do in the moment in time was to allow preschool teachers to look at their own practices and make their own changes. And therefore, they invented a near-term proxy. And I'm going to show you an example of this.
The slide shows a diagram with two boxes. The box on the left reads near-term proxy with a question mark. It also reads process instructional time and instructional quality. An arrow point from the box to another box that reads outcome, children's early language and literacy skills. The next slide reads, Plan Do Study Act. Model for improvement. What are we trying to accomplish? How will we know that a change is an improvement? What change can we make that will result in improvement? Below is a circle divided into 4 quadrants with arrows pointing clockwise. The quadrants are labeled Plan, Do, Study, and Act.
So we were using the model for improvement that uses 3 questions to guide program staff to make changes and PDSA cycles. The first question of what we're trying to accomplish, the teachers themselves answered. We're trying to improve our children's language skills, but specifically vocabulary. How we'll know a change is an improvement is the question about what measure are we going to use. And the measure that the study uses is the Woodcock-Munoz, which is standardized and internationally validated. It's a direct assessment. But the teachers said they're going to measure the number of children who could use a new vocabulary word with help and the number who could use it without help. And that was their homemade measure. The change they wanted to make that would result in an improvement was introducing one new vocabulary word per day using rotating instructional strategies. Some of them were part of the professional development, some of them came from their own experience. And the PDSA cycle invites them to ask their own question, much like developing your own hypothesis before you do an experiment. So if we introduce one new vocabulary word each day using rotating instructional strategies, will the number of children who can use these words without help increase in practice? They planned it. On the next slide, you'll see the do. They did this.
The next slide shows a line graph with two sets of data in blue and red. Data is on the x-axis, the number of children on the y-axis. The red line shows the number of children who use the new vocabulary word without an adult's help, and the blue line shows the number of children who use the new vocabulary word with an adult's help.
And they studied it. So they collected data daily, and they did reflection on this weekly. And the chart on the left-hand side shows the number of children who can use the new vocabulary word. The blue line is with help, and the red line is without help, and the x-axis are days. So they did this every day. Right? And you can see roughly that the blue line goes down and the red line goes up. And the teachers use this to see were children using new vocabulary words without help. In the study, they concluded that these strategies were working, but also that there were words that were harder than others. And in their ACT, the last step, they adapted this to say, for especially hard vocabulary words where we introduce them and a lot of the kids need help using them, we're going to introduce that word again later using a different instructional strategy, doing reinforcement.
The next slide contains 4 charts. On the left side, a line graph is titled, Near-Term Proxy. Daily. Participants collect in PDSAs. Below is a bar chart titled, Near-Term Proxy. 3 times per year. Participants assess students. On the right is another line graph titled, Process Measure. Daily. Participant Report. Comparison, self and peers over time. Below that is a line graph titled, Process Measure, Validated Assessment. Comparison to self and peers 3 times per year.
So we used a lot of different measures for the program improvement portion of this. The top 2 are teacher-reported measures that are collected daily. So the upper left-hand side is the measures we just talked about. The upper right-hand side is teacher-reported time spent on language instruction every day. And we have a lot of conversation within our own program about how valid these measures are. They're not standardized measures, they are self-report, and how much it matters. So for us, the choice was made that these are really made to empower the teachers to reflect on their practice in different ways and to make changes in day-to-day practice. The upper right-hand corner, at the beginning of 2014, which is the lower line, the average number of self-reported minutes spent on instructional time for language per day was 5. And at the end of the year, you can see that it was close to 60. I wouldn't bet my life that it's really 5 and not 8 and not 4, but I'm convinced that 5 is different from 60, even through teacher self-report. Okay, the lower 2 measures, the lower left is a formative evaluation. This was a part of the teacher's practice that existed, and we used it and started graphing it and looking at it for the project. And the lower right-hand corner is a class assessment, and this is a validated standardized measure based on full-day videotaping. That sort of measure we can only get 3 times a year. If we think about the comparisons that Scott outlined, these are all comparisons to self over time, right? And so it's not the same causal analysis that the foundation still always prioritizes. So on the next slide, what I'll show is the effect sizes from a quasi-experimental design using the Woodcock-Munoz. So this is a validated international direct assessment of children's language. The comparison is between children in schools that got this teacher professional development intervention to children in regular preschools, right? And what you see here is that from year to year, we've seen an increase in the impact of this intervention on 3 of the children's language outcomes, with effect sizes between 0.2 and 0.3. The other point about this is that you can only do it, we could only do it every 2 or 3 years. So we're convinced that the increases in impact of our intervention are driven by the behavior changes based on the measures that were taken on a daily basis and 3 times a year by the teachers themselves.
The next slide reads, example, how might we? It sets up a hypothetical scenario with 3 factors. 1. Individuals who have completed detox and are at high risk of relapse once back in their communities. 2. Post-detox programs can help reduce the number of relapses. And 3. The program dropout rate is high.
So we wanted to walk through an example, a real-ish example. This is a synthetic example of a situation where you have kind of a general context, but with slight variations in some of those framing questions, it would lead you to 2 different approaches, specifically one approach using PDSA cycles in a breakthrough series collaborative versus one approach using an RCT. So we've come up with this example. I'm going to set the stage for the example, and then we're going to talk through 2 different scenarios of those background questions with some minor differences and see how we end up with 2 different approaches. So the situation is, we're an agency that runs programs to help individuals who have substance abuse, addiction problems when they come out of detox to help them avoid relapse. We know that people coming out of relapse, they have a high risk of, people coming out of detox have a high risk of relapsing once they get back into the community. We also know that there are these evidence-based programs that if they participate in them can reduce the risk of relapse, but the programs only work if people show up and they persist through the program. So we're an agency that runs one of these programs, and we have a high dropout rate. And we want to test a package of services to reduce that high dropout rate of people who enroll in the program. And that test is going to include a couple of things. One, a risk assessment, assessing the risk of dropout. So for people who are coming into the substance abuse program, what's the risk that they're going to drop out? We're going to give them a risk score. And then for those people at the with a high risk of dropping out, they're going to get some combination of services that will likely include text reminders. It'll include assigning them a mentor. It'll include incorporating their family members in the therapy, and it'll include potentially home visits, the counselor making home visits to the person, all intended to keep them in the program and to persist. So let's talk through the 2 scenarios.
The next slide reads, comparing the questions. A table shows a list of questions and columns listing answers, depending on which of 2 scenarios are considered. The questions include, what outcomes do I want to change? And what data are available?
All right, so in my version of reality, what I'm trying to understand is if this effective framework, which has been tested in other programs with a very different population, can be effective and can be adapted to reduce dropout in my program with my clients. The outcome that I care about is substance abuse relapse. The proxy is reducing dropout in the program. And the results are going to be used by the program staff and the program director. This is a high priority for the organization. And in this scenario, the risk of a false positive is low. So if I test a bunch of these things and I believe that this combination of things reduce dropout, and actually it wasn't exactly that combination of things, it's not as important to me. How hard is it to implement the innovation? It's moderately complex, and how much will building and engagement of the program staff is needed. I think that I need moderate will building of the staff in this case. I've got staff who are very committed to what they do, and this is true in substance abuse prevention programs. Many of them have come through substance abuse themselves, and they believe their experience. And they think that what's worked for them is going to work for everyone else. And so I need a model that's going to allow them to test and try things and let them succeed and fail and increase the buy-in as they experience this in their own practice. I'm not going to be able to come in and say, do these 5 things and have people do that with conviction unless I have something that builds well along the way. And that's one of the reasons to choose BTS in this case. The data available are participant history, the risk predictor, the daily attendance, and program compliance. I expect these results in 9 months, and the near-term proxy is 6-week dropout rates.
So my situation's a little bit different. We have this package of services that includes risk score and text messaging and mentors and including family and home visits. That has been tested in other communities, and it's shown to reduce dropout rates. However, with my agency, and my staff are frustrated by the dropout rates that we have, and they're eager to try something new, and they're familiar with this model, and they want to try it. But our agency doesn't have a lot of resources, and these are resource-intensive components. In particular, the home visiting takes a lot of counselor time, and I know that if I'm going to roll this out agency-wide, I'm either going to need to find resources to add counselors, or I'm not going to be able to serve as many people. So what I want to do is test, can I streamline these services? Can I reduce the components here in a way that I can leverage my resources without having a meaningful reduction in having the same impact on dropout rates, a reduction in a reduction. So the situation's a little bit different. My question is, can the components of an effective framework be streamlined to reduce dropout? Again, ultimately, I'm interested in reducing substance abuse relapse. It's really the program director who's using the results here to make a decision about what's being implemented. It's not necessarily the staff using the results to figure out how they're going to integrate this and innovate on this with their services. This is a high priority. What's the consequence with the risk of a false positive? Here, it's moderate. If I am wrong, I run the risk of either rolling out a program that actually doesn't have an impact on program dropout, or I run the risk of rolling out a program that's more expensive than it needs to be. So I want to be confident in what's having, a little more confident in what's having an impact here. In terms of will building, like I said, it's not as important here. The staff are on board. They want to use data. They want to use the prediction. And we think we can get them to adopt this with fidelity. All other aspects are the same between the two scenarios.
The next slide reads, comparing the timeline. It contains a 9-month timeline. BSC is on top and RCT is on the bottom.
So how does this roll out in a timeline? In a breakthrough series approach, there would be a preparation period. We've given it a month to design the theory and the measures. We'd recruit a team of experts who know the evidence base, and a team that includes frontline providers who can help us define that theory with short-term process aims and longer-term outcomes. In this case, 6 weeks is the longer-term outcome. In month 1, we'd recruit the programs, and as we recruit programs, we are going to coach them to form teams that include different participants across the levels of the program, ideally including clients, program recipients, potentially graduates of the program. And we will prepare them to work together using these methods. In month 2, we would run a learning session. This is where the theory of change would be taught. So they'd be taught by the experts in that committee, including the frontline mentors, and they'd be taught how to run PDSA cycles. Specifically, how am I going to ask, if we test X, will it result in Y? In what period of time? With how many clients per week, per day? How quickly can I do this? But training people to use the interventions, those text messages, mentoring, et cetera, and also to use these methods as a team happens at the first learning session. In the months in between months 2 and 5, teams go off and practice and test and learn, collecting the daily attendance and the dropout rates and looking at that data as they go. There's monthly supports where everyone comes together, typically on virtual calls or webinars, to review data across sites and to have teams that are having a lot of learning, either successes or failures, present their experiences. At learning session 2, you can dig deeper into the theory, refine any pieces of the intervention that need refinement, and really have the team start teaching one another what adaptations are working. And then they go back into their sites and practice from month 6, 7, and in 8, they come back together to look at the data across the entire group and comparing and achieving those results. In month 9, typically, We bring back together that group of expert faculty, and we may now have new frontline provider experts that choose to join to refine the theory, refine the measures, and slim down those adaptations of the 4 interventions they tested to get something that you think is tested and available for future use.
So we can also do the RCT in the same time frame. We would start, again, with basically designing the approach and figuring out how we're going to measure the outcome of program completion, figuring out how we're going to monitor fidelity to the different program models that we're testing. We would recruit sites and counselors into the study and train them in 2 different sets. So in one set, we're going to train the counselors in using all of the components of the intervention. And in the other set, we're going to train them to do everything but the home visiting, because that's the thing that we want to test. And once we get them trained, we'll start randomly assigning new enrollees, people who are coming out of detox, enrolling in the programs. We'll assess risk and assign those high-risk people into one of the 2 treatment arms, and we'll let that run as people cycle into the program. We'll let the 2 treatment arms play out and monitor program completion rates for the 2 treatment arms. We'll also do work to monitor fidelity to make sure that that counselors are actually, adopting these, incorporating these services according to the model. And then at the end of the study, we'll look at the results and make some decision based on that.
The next slide reads, contrasting the approaches. Below are 2 columns for BSC and RCT, detailing monitoring, outcomes, and questions answered. At the bottom, each has a green check mark labeled pros, and a red X labeled cons.
So to contrast these 2, the approach of Breakthrough Series on the left is going to monitor more measures, actually. The daily attendance, retention to 5 visits, time between visits, program completion. The sites will annotate their own data with the interventions and the adaptations they make to those interventions. The outcomes are going to be daily return rate to the program and the program completion rate. And at the end, the questions will answer, and depending on the way the measurement system is defined, you may use a statistical process control chart, which fits on the moderate level of complexity and the moderate level of confidence of Scott's table. Or you may use run charts. And the question will be, did the dropout rate shift significantly after we developed, refined, and implemented a new process? By how much? And which adaptations were associated with that shift? So this is associations between adaptations and a shift that will have differing degrees of statistical rigor depending on how you set the charts up at the beginning.
And on the RCT side, we are going to monitor daily attendance. We will monitor program fidelity. The outcome of interest is the program completion rate. That's what we're going to use to make an assessment here. The question we're answering is one combination of these services more effective at reducing dropout than the other? And if so, by how much? And in particular, what's the cost effectiveness of each of these combinations? And that's, in thinking about the pros and cons of at least the RCT approach, it really, the benefit here is that we have confidence in any sort of causal inference that we're making, but we also get a more precise measure of the impact, and that can be beneficial in a cost-benefit analysis. The cons of the RCT are that this is a fairly locked-down approach, at least the way that I've presented it. We are going to roll out these 2 different models, and we don't want staff to innovate with them along the way. We want to make sure they're doing the model with fidelity so that we know what it is we're actually testing. And so that's one of the cons of this approach.
Now, one last thing before we wrap up. I think another contrast between these approaches is what happens to your program staff throughout these experiences. So for some social service interventions, and I'll use home visiting as an example, the home visiting coin, Mary McCrane's in the audience here, HRSA has done an intentional push to build the capacity of frontline providers to do this kind of rapid cycle testing. And so coming out of a breakthrough series, what we may see, what we have seen in home visiting and what we may see in this experience is the program staff may be more prepared and more ready to incorporate other innovations in the future, right? So the transformation of the frontline providers and potentially clients or patients as partners in the work and as innovators and as potential adapters of improvement is transformed through a breakthrough series experience in a way that it typically isn't in a different RCT design.
Yeah. Okay, we have a couple of just final takeaways, and then we'll open it up for questions. The main takeaway here is let the context determine the method for rapid improvement. This includes focusing on decision maker needs, assessing staff readiness for adopting the intervention, and assessing the level of confidence that you need in the findings. A second takeaway, factors that drive the timeline, they are context specific, so it's not necessarily the case that the RCT is the longest. How long does it take to observe an impact? Are there proxies available if that time is too long? What data are available? Can you get the data readily? And what's the flow? What's the sample size of participants through the program? But I think the biggest takeaway from my perspective is that this type of improvement work, this iterating, learning, and improvement work is great work. So I'm very happy OPRE is having this conference because I think we all need to keep doing this. I don't know, do you have other takeaways to add?
The only other comment I would make is that I think the Chilean example is illustrative of the duration of investment that needs to be made to really adapt and tweak interventions to achieve the kinds of outcomes that social programs aim to make. And it's really rare to see RFAs that commit to that up front or provide the mechanisms that say, we have something we need to learn before we can RCT, or we're going to RCT and then we're going to have more to learn, whatever that is. And so for the 60% of the government agencies and funding agencies that are in the room, I think I've seen some new RFAs that kind of take this longer view, but the experience and the learning and the impact we saw in children's outcomes in 2015 would not have happened without starting in 2006 and continuing that work with a variety of methods over time.
The next slide reads, questions?
Great, so we're happy to take questions on...
The female moderator and a male audience member approach the microphone in the center of the room.
Up for questions, I just wanted to remind folks to please state your name and affiliations. Thank you.
Hi, I'm Steve Bell from Westat. In these very rich examples, I learned a lot. I want to zero in on the R word, rapid. Besides being willing to assume that an intervention with a lower dropout rate reduces long-run recidivism more, what aspects of the research approach made it faster?
Steve returns to his seat.
So in the, well, I think it is focusing on, we're testing not the full intervention, but a change to the intervention. And then, yeah, focusing on, in the RCT example, program completion rates as, ultimately a proxy for reduction in recidivism, as you said. That also reduces the time frame. I don't know if that answers your question.
Yeah, I agree with that. I also think that the rapid cycle learning that you see in the breakthrough series examples can refer to the learning that happens on a daily basis because of the cycles of questioning and answering that you're doing with data, or a weekly basis in those reflections. So for example, between a first learning session and a second learning session, typically what we're looking for are specific sites or participants that already have shifts in their data, right? So in an RCT, you wouldn't see a statistically significant difference until you got to the end, which is why you designed it to be the end. But in the breakthrough series, if you're willing to accept that these proxies that are measured more frequently can show statistically informed shifts on run charts, then you can learn in rapid cycles before you get to the full sample size. You'd want those first, at the second learning session, typically we're looking for superstar sites that have something to teach other people. And you can see successful adaptations to how I talk to parents about developmental surveillance and screening by using this half sheet, spread like wildfire across programs, and make the program staff more comfortable in having those conversations. So rather than relying specifically on the model is this, if we can get people to fidelity, we'll get to what we want. In the rapid cycles, to me, speak to that shorter term testing and learning by the staff.
Yeah, I mean, and I think it's useful to think about what we're talking rapid relative to what? Rapid relative to how programs have kind of developed and improved over time historically. And this is going to be a complete overgeneralization, but if you think of a model where there's a university that develops a kind of a program in the lab, they roll it out in their local community, they have evidence that it works. That model wants to get adopted in other communities. You end up with a this is rolling out over years. A multi-site evaluation of that model happens that takes multiple years to complete. It's a number of years before you start to have evidence of is this working or do we need to improve? Where what we're talking about is sort of along that way, you're testing and improving based on short or near-term outcomes.
A female audience member speaks into a microphone.
I agree with you that this kind of learning cycle happens all the time, and these are in learning organizations and organizational learning and individual learning, and that's so important in this cycle. And I was thinking about rapid cycle evaluation, and well, it's really cycle evaluation. Well, it's really evaluation cycle that your presentation, and I think the intention here emphasizes that it's this continual learning. And so my proposition to you is maybe and to all of us, is reduce emphasis on the rapidity, because sometimes it's really important, but I wonder if it sets up expectations among all stakeholders that just aren't realistic in some cases, depending on the data, depending on what the question is, and maybe increase the presence of something like a logic model or a theory of change. And you talked a little bit about it, but in addition to thinking about the methodology and sort of confidence or risk of a false positive, can you talk a little bit about how you think about development, adaptation of the theory of change or the logic model, or either one, working into the system?
So on your first point, I personally have no problem, getting rid of the word rapid. I think you make a great point that it does set up expectations. I've had a number of people who approach me looking for rapid cycle evaluation, which they think is sort of a traditional full program evaluation, just quicker. And that's not what I'm talking about when I talk about rapid cycle evaluation. So I have no problem sort of stepping away from that word. And I think that's a really good point that would be useful to sort of discuss throughout the next 2 days of this conference. The second question was, how do we incorporate a logic model into sort of the framework here? Do you have thoughts on?
Yeah, to comment on that, I mean, that was one of the biggest differences between the first phase of the Chilean work and the second. We always had a theory of change. We always had measures associated with our moderators and mediators, as we referred to them in the RCT. We talked about it once a year. And in the second phase, which was the breakthrough series, the first piece of work in that expert meeting was to adapt that theory of change to a key driver diagram, which is a different format that's a little more accessible. And that was in front of our frontline teams at every opportunity. At every learning session, in between the learning sessions, the process measures and the outcomes hung directly on what the drivers of improvement were. So I think that's a place where a lot of progress can be made, and I appreciate you highlighting it.
Yeah, I mean, rapid testing is not a substitute for traditional program evaluation. And I think the Chilean example really, is a great example to demonstrate that. And I think that, having a logic model, a theory of change, can be really valuable in figuring out, in the improvement framework, if I don't have a lot of time to wait to observe an impact, what are my potential near-term proxies?
A female audience member speaks into the microphone.
Principally from Child Trends. And I wanted to bring out one other piece of the conversation that's sort of underlying right now, which is what outcomes can be used in these models and frameworks. And I know in the Precision Home Visiting HARC study that Mary Catherine and others and I are in the room, we're talking a lot about the importance of mediators and building stronger connections between our mediators and long-term outcomes so that we can more look at proximal mediators in these kinds of models to look at change rather than having to wait for that long term. And it seems to me that from the discussion already that these methods can be used clearly for implementation factors because they're often closer. But then having to look at these sort of near-term mediators. But can you talk a little bit more about kind of the outcomes that you've seen used in these and how those things play out?
Sure. I mean, there are some outcomes, and I'll use examples in healthcare because I know them. But there are efforts to improve outcomes in things like door-to-balloon time with heart attacks. So if you get your cardiac arteries dilated with a balloon within 45 minutes of when your heart attack started, you will do much better, right? So in a high volume cardiac center, you can test an intervention and watch your door-to-balloon times. And that is a shorter term proxy for cardiac mortality and cardiac function after a year. But that is the link, as you referred to in the home visiting stuff, the link between that and your outcome is tight enough that you don't even have to include it in your introduction anymore. You don't have to explain or justify that. An example from the Chilean project is we used full-day classroom recordings to score the class 3 times a year. And the class has 3 domains of classroom quality. If you score above a certain threshold, you can see impacts on children's outcomes. So that link is fairly strong. In 2014 and 15, we started training teachers in the class and training our teacher coaches to score specific pieces of the class based on 20-minute classroom observations. So the coaching model always had 2 classroom visits in a month. It always had a planning session, an observation, and a reflection after it. We overlaid non-validated class scores, right? Direct observation of a specific portion of the day to help teachers focus on specific pieces of their practice. And we monitored those twice a month over time and showed increases in their class scores with these non-valid scores that did correlate with 3 times a year and end of year class scores. So that's an example where the outcome itself could be used in a somewhat in a less appropriate, less rigorous, less validated way to drive improvements in practice. But it was the outcome itself. And what's fascinating is, we have people on our evaluation team who are like, that's nonsense, that can't be done. And then we presented it to the developers of the class, and they're like, that's really interesting. So it depends on where you fall along this spectrum of rigor, but I think we should be open to using measures that are the outcomes themselves, if it's available, even if the way it's collected and the way it's gathered wouldn't stand up to self-correlation, to inter-rater reliability, and to all of the rest.
Yeah, a different example, I know a sort of employment training program for ex-offenders that's gone through MDRC, did a great randomized control trial evaluation of the program, and it didn't have the big impact on long-term earnings, long-term employment that the program wants to have on ex-offenders. And the program includes sort of an intensive job skills training component and then a transitional jobs component. And the program administrators, they didn't sort of look at the results and say, oh, that can't be. We are having an impact, we know it. They looked at the results and they said, well, we have this attrition problem from after the intensive skills into transitional employment, people are dropping out either right at that seam or shortly after they enter transitional employment. And that if we're going to have an impact, we need to increase persistence. So they're not saying that that's ultimately the measure of success. They're recognizing that the next time someone comes along and evaluates us, if we want to show a bigger impact, this is the thing we can't have an impact if we don't address the attrition. And so the attrition ends up being the outcome that they've, basically through their logic model identified as this is where we're potentially falling down.
The audience turns to look at a microphone on the far left side of the room, which is off screen.
I'm Saima from CMMI. The rapid cycle evaluation is actually part of our group's name, and we're constantly under pressure of delivering something quick and fast. The hesitation, however, I really like the term near-term proxy. However, the hesitation is, what if the direction or the magnitude is not consistent with the impact analysis at the end of the term of the evaluation? So I wonder if you can share some insight on how do you select the proxy measures, and how do you frame it and convey the message when the proxy and the long-term impact analysis are not consistent?
Just actually, if you could, if I make sure I understand the question. So is the scenario that you're talking about, I've identified this near-term proxy. I'm running a test to see if I can improve that measure, and it's not showing improvement?
No, I'm thinking more in the scenario where your proxy shows something like improvement, right? And you keep telling your model team, oh, the intervention seems to be working based on the proxy measures. 2 years down the road, you do the impact analysis of outcome measures, right? We deal with health outcomes, which take years to show result. Mm-hmm. Then you don't find anything. How do you convey and explain that? Because that happens a lot of the time.
Yeah. I mean, in the example I was just talking about, the employment and training example for ex-offenders, let's say they implement a change and it includes persistence. They get evaluated again, and there's still no impact on long-term earnings. I think that's the scenario that you're talking about. Well, then there's a question of looking at kind of the theory of change for this program. Where else might we be falling down? Are there things we can test to improve, or is it there is a tough conversation to have of maybe this model is not effective, and so I think that again, the value of a traditional program evaluation is still valuable, because you need that sort of objective assessment of, is this program effective? Is it worth it? But you're only going to maximize your chances of showing a positive impact with the program evaluation if you test improvements, along with your theory of change along the way.
Yeah, I think that this question calls back to what Lauren was trying to highlight about, what are these near-term proxies and how tight is that relationship? And so my suggestion was, let's use the real outcomes, even if the measure is less reliable and standardized. The other thing is to rely on your theory of change. So in the Chilean example, we had very big impacts on the class, really big impacts on the class. People anticipated we would have big impacts on children's outcomes. And at the end of the study, what we were able to then learn from it was that the impacts on the class were statistically significant. The effect sizes were big, but the instructional support was still scoring below the target, which was 3.25 out of 7. The instructional time effect size was very big and statistically significant, and when you looked at the data, it was the difference between 5 minutes per day and 12 minutes per day spent on language activities. And when we did the moderation analysis for attendance, the positive impact on children's outcomes happened among the quintile of children who had the greatest likelihood of attending, so it was causal. But anyway, who attended the most? And those kids still missed 16% of school days. The average chronic absenteeism rate in our classrooms was 66%. So that doesn't mean what the teachers are learning and doing doesn't work.
A female audience member walks to the microphone as she fans herself.
It means the kids aren't there enough to get it. So I think that the question that you raise, what happens when your near-term proxies show something and your outcomes don't, to me, it just makes it interesting. How did that happen? Is the relationship between the proxy and the outcome false, or are there other things that you can see that were in your theory of change that played a role that you can address in the next iteration?
The audience member at the microphone speaks.
Hi, I'm Alita Meyer from the Office of Planning, Research, and Evaluation, and I'm super excited to hear this conversation. It reminds me of a paper I was forced to read for my doctoral defense on program development evaluation, which was Gottfredson made a modification to action research. And one of the things that you're alluding to here that I want to emphasize is the aspect of the worldview of the people implementing the program and the disconnects that can exist between a theory of change that a social scientist or anthropologist might develop and people on the ground. And I think that that issue of will building is really important, and it brings to mind something somebody said to me a couple days ago who had gone through training to be a foster parent, and she's an assistant professor of psychology, and the other people in the room who are also learning about being a foster parent were really most frustrated about not being able to use corporal punishment. And just thinking about, I think that's for human services to think about the ways in which our efforts to change behavior in really important ways, we really need to get into the worldview of the people doing the work and take that seriously. And I think it's exciting. And I just was wondering if you had examples of that as well, or I don't know, I just wanted to exclamation point that.
Your domain.
Yeah, I mean, I really, one of my passions, one of the things I like the most is coaching and working with teams that bring together people across a diversity of training backgrounds and life experiences, right? So clients, patients, paraprofessionals, and professionals and CMOs all at the same table, and the power of personally relating across, across these societal boundaries and telling stories across them and discovering commonalities and discovering real differences like the one you described. So I love the CQI approaches and the team-based learning that facilitates and requires that. It's challenging. I'm sure we'll hear about some of the challenges over the next 2 days. I think it's tough because even in our first phase of the RCT in Chile, we tried to do that. We had a strong stakeholder engagement. We did what would be called community-based participatory research methods in building the intervention. I just think that, you know, there's a limit to truly how open we are as researchers when we're doing something that requires what we do not change, right? So I do think that we can do fidelity of implementation better in ways that are more respectful and do that within an RCT. But I think if we've got a transformation, a culture change, and a workforce renovation issue, as we do in healthcare with burnout, as we do in lots of social services, there are some of these methods that are actually useful to that end in and of itself, as well as potentially improving the outcomes of the recipients.
The moderator stands at the microphone with an audience member.
We're going to take one final question before we break.
Hi, Pamela Velez Vega, Millennium Challenge Corporation. Excellent presentation, thank you. I was fascinated when you mentioned that in the teacher intervention, the combination of what the teachers were doing might not be that important, but it was the possibility of them trying and becoming empowered and understanding, you know, what is working for them and making adaptations. And that just made me think of a very dynamic cycle, right? Like feeling a lot more mindful about like what you're doing, reflecting as a teacher. I'm imagining reflecting on what you're doing and being able to catch yourself in the moment and that. So if you could expand on what were some variables that you were using, if you were using in terms of, the teacher being more empowered, or changes in behavior specific or attitudes of these teachers as they were going through the program?
Yes, let me back up just a second, because I want to make sure I didn't misspeak. What the teachers did and the content of the professional development itself, the teaching strategies, the ways they were trained to use open-ended questions or a word wall, or the strategies, were really important. I have worked on breakthrough series where the evidence base and the intervention itself wasn't completely vetted or strong, or the theory of change wasn't completely clear, and it's really hard. So that's important. I think the breakthrough series that worked in Chile benefited hugely from having the testing through the randomized control trial. The home visiting coin has worked really well because the evidence-based interventions that went into it they exist. We have home visiting models, okay? So let's not discount that, because if you try to do this work without it, it's really challenging. That being said, there really were transformations in the teachers, and we didn't intentionally set up a qualitative study to examine that transformation. But we did, in the development and the series of these, develop mentors and later interview them. And we have beautiful videos of them talking about their experiences that I'm happy to share with you, some with subtitles. But one of the things that I love is one of our strongest teacher mentors said, "I used to hate PDSA cycles." She said, the data is complicated. Writing down what the kids said or didn't say takes time. Like, I used to hate these, but that's where the learning happens. And so really engaging them as learners and as people who came into this profession with a passion, and that are still there for the same reasons, but looking at the data in ways and helping them learn and grow, really transform them from recipients of a training they were meant to execute with fidelity to protagonists in innovation. And that transformed their own practice, but also led to many of them seeing themselves as mentors for their peers for the first time in their lives. So that was exciting. And I'm happy to share those videos with you if it's something you'd be interested in seeing.
So the last thing I'll say, because we're about to get ushered off the stage here, is program improvement is hard. If this wasn't hard, we wouldn't be here today having this conversation. And it's something that does require all levels to be involved and engaged in the program improvement effort.
The audience applauds. OPRE logo. Office of Planning, Research, and Evaluation. An Office of the Administration for Children and Families. acf.hhs.gov/OPRE